Hello everyone, and here we are at the end of our program. Everybody's here, ready to graduate and move on to the next step in their lives. What we will be presenting today is over the current criteria for interventions in collegiate baseball pitchers sustained a slap tear, critically appraised topic, by Alexis Blunk, Louis Matriciano, and Genesis Sagan. As we continue into our clinical scenario, a brief summary of the scenario. The repeated overhead throwing being the number one mechanism of injury for collegiate baseball players, the rehabilitation protocols have provided insufficient results of the evidence. With the different grades of tears that an athlete can sustain, there should be a different protocol for each individual case, each case predetermining which directional need for intervention should be used. While most tears may be necessary for repair, non-invasive procedures would be preferred in many cases for a potential faster return to play. A grade 1 tear being the partial tear and degeneration to the superior labrum, where the edges are frayed but the labrum is not completely detached. Suggestion would be treatment to debride if therapy does not work. A grade 2 tear being the most common of slap tears, where the superior labrum is completely torn off the glenoid due to an injury such as the shoulder dislocation. This injury more commonly requires surgical repair arthroscopically. And lastly, grade 3 tear, also known as the bucket handle tear of the labrum, will actually impede an athlete's ability to move the arm at times, locking or causing sounds of clunking motions. The tear also requiring surgical repair. With the superior labral anterior-posterior tear occurs from the tension placed on the biceps labrum complex in the cocking and releasing phases of the throwing motion. The severity of the tear is associated with the intervention a patient receives, also by surgical or conservative treatments. The conservative interventions involve a rehabilitation-based return to play or activity. The results of a conservative approach are inconclusive. So, moving on to our clinical question. For collegiate baseball pitchers with slap tears, what is the current criteria for the rehabilitation in the process for return to play for baseball pitchers to have a safe return to activity? The material collected was used through peer-reviewed articles, each of which ranged from the years of 2013 to 2018. The inclusion data of these articles was on the population of collegiate baseball pitchers who had sustained a slap tear and undergone the conservative and or surgical interventions. The exclusion data included individuals sustaining secondary injuries other than a slap tear, the secondary setting athletes, and non-overhead athletes who have suffered a slap tear were also excluded from the study due to the target population being college setting. Through the use of the Joanne Briggs Institute tool, this was used in validating the reliability of the research used, the comparison of the results of the methods of intervention and outcomes through conservative and invasive treatments, and the use of data from studies to help construct rehabilitation protocols aiding in stronger positive outcomes. The three main takeaways, or our three main findings from the articles we found: 1. A phased rehabilitation protocol can be beneficial for slap patients who opt out of surgery. Moore, Reed, and colleagues created a rehab protocol for 10 patients addressing the range of motion, strength, and neuromuscular control. These are considerations for athletic trainers to have when designing a phased rehab protocol. 2. A second finding was in a lab study conducted by Cools and colleagues. They investigated the maximal voluntary isometric contraction in different muscle groups on 16 common shoulder rehab exercises. The exercises were then rated from low to high muscle activity. Although it was done in a lab setting, developing an exercise progression for certain muscle groups like the biceps brachii, which can be involved in a slap injury, can ensure the rehab protocol is appropriate due to restrictions. And 3, the third finding was the return to play rates for pitchers and non-pitchers. Based on the questionnaires given by Gillum and colleagues, they found a total of 63% of players returned to activity after SLAP surgery. A total of 59% of pitchers had a successful return to play. A total of 76% of non-pitchers returned to activity. When looking at these return to play rates, athletic trainers can improve these outcomes by having a protocol in place and educating the athletes on the role of rehab in returning to play. Now we move into our conclusion. Although the level of evidence was low for the articles selected, each one had important points to consider when working with baseball players with SLAP tears. Each study has its limitations, and future studies need to focus more on baseball pitchers who have undergone a conservative rehab protocol or surgery with a rehab protocol. Lastly, now we get into our questionnaires, everyone. So first, what has your experience been with treating patients with SLAP tears? What stood out in the evidence presented in the presentation? Are there similarities to the protocols recommended that you already use? What have your results been? And do you have any objections to the data provided? And if not, then what was a key point that you intend to use in future rehabilitations? Thank you, everyone, for taking the time to review our topic on the current criteria for interventions in collegiate baseball pitchers sustaining a SLAP tear, a critically appraised topic.